Okay, we might kick off then. So, good afternoon, everybody. Before I start today's webinar, I suppose I might introduce myself. I'm a fresh new face, or maybe not so fresh, but new face. My name is Laura Milani. And before I start, I'd like to express my sincere thanks to Professor Michelle Leach, who has founded these CPD webinars and led them to great success over the last number of years. So thank you, Michelle, and it's my great pleasure to step into her boots following her leadership. It's also my great pleasure to introduce Ciaran Malone. He's our speaker this afternoon, and Ciaran is a senior medical physicist at the St. Luke's Radiation Oncology Network here in Dublin. He serves as the St. Luke's Institute of Cancer Research Fellow in AI and Adaptive Radiation Therapy, and he was recently awarded the Best Application of AI in Healthcare at the Irish AI Awards. Just a reminder to everybody, if you're new to the webinar, your mics are muted and they will stay muted. So if you have any questions that you'd like to direct to Ciaran, please use the Q&A box and I'll put them to Ciaran at the end of his talk. So today, Ciaran is going to share his insights in the evolving role of AI in our field, and his lecture is entitled AI in Radiation Oncology: Hype, Hope, and Hard Truths. So, Ciaran, the floor is yours, and you're very welcome.
Cheers. Thank you so much, Laura. Share away. So yeah, thank you so much for the introduction, Laura, and for inviting me here today to share some of our experiences that we've gained both through researching AI, developing AI-based tools, and deploying some commercial AI tools in clinical practice. So I've been quite lucky, I think, to be in a unique position as a Slicker Research Fellow over the last 2 or 3 odd years, being teamed up with a Radiation Oncologist Fellow and two Radiation Therapist Fellows who've been just brilliant to work with. And I really think I've brought the full MDT perspective to the table, which I hope to share with you today. So I hope that you'll come away with a good feel for what to expect from AI tools, kind of what's behind the hype, what we need to know about AI in clinical practice, some hard truths, and with some hope for what effective human oversight of AI tools might achieve in clinical practice. So most people, I think, would assume that the top equation here is true and that the hype suggestion is almost a given, where human plus AI would be better than human alone or better than AI alone. However, where we might end up, or where we might actually be currently ending up, without ensuring some sort of effective or responsible synergy of that AI and human collaboration, is the formula down below for patient care. And that's where we don't want to be. So I do think that a lot of us are in different portions of this Garter type hype cycle at the moment, where I do think that, some people might be in the hype area, where you'd have to move past that, learning some kind of hard truths and see where AI is strong and weak and where its limitations lie, before coming back up here and really getting hope towards productivity. So I think that's what I'd like to kind of focus on today is more so how to get that effective human oversight role correct. So there is evidence that we've not yet reached that optimal synergy of human plus AI. So without dealing with some of these hard truths around experience, expectations, education, we may struggle to really safely deploy AI tools clinically. So you see here in these two papers where AI plus human did not significantly outperform AI alone. Now it did outperform human alone, but there's something that we're not quite getting right here, that when AI and human come together, the results spread it out and they were less than AI by itself. So it's just something to think about, is that we really do need to consider how we marry up and work best with AI, especially to make sure that we're offering the best outcomes for our patients. I was and did start off a little bit critical, so I did want to bring in a little bit of positivity too. So there's huge potential for AI. It's been integrated into every aspect of our lives. You can see it here being used by my daughter, who's an avid comic book kind of creator, designer. She loves writing stories about animals. And for her, the delight of putting it into an AI system like ChatGPT or Gemini and having it be her creative designer, her editor, her graphic designer, and producing something more polished and production ready was just brilliant. She was absolutely delighted. So it's filling in her skills gaps because as a 9-year-old, it's not the types of skills she's developed yet. I'm sure she will in the future, but for this point in time, it fills in her skills gaps. Uh, it didn't get everything perfectly right, mind you, but she didn't mind. But for us in a healthcare setting, it is a high risk, complex clinical environment, and it does require a little bit more caution and effective oversight. So instead of filling in our skills gaps, it should really support and complement our skills already. So I think if we can focus on doing that, I think we'll be in a really good place. There's this idea of effective human oversight. I mean, it's in the EU AI Act as a requirement, and the idea is to prevent or minimize the risks to health, safety, or fundamental rights when a high-risk AI system is used in clinical practice. So you would have seen things before like fairness and ethical use, for transparency and explainability. But also, I mean, I did want to focus on a couple of areas that I didn't think were really highlighted in a number of other talks, which I really wanted to focus on, which was, we do have to acknowledge the weaknesses in our own healthcare data. It's not perfect. We're still working with written records in some cases. Often there's no consensus between two different people of what is the ground truth. And also then when we get an output, how do we adapt that output and learn the skills required to take an output from an AI and adapt it to the clinical context? Because I'm sure AI can take the inputs we give it and give us a really nice, probably very highly accurate answer. But until it comes to the medical profession that knows what that family is going through, the history of that patient, how that patient felt in that waiting room or in that clinic, that's when the context of clinical skills and the experience that comes from a healthcare professional really comes back in, which I hope we can really focus on as well. Now, where we lie in radiation oncology, I think we're in a really advantageous space because we are not, unused to change. We've huge experience in making or having automated tools, processes, complex optimizers coming in, going from manual dose calculations on pens and paper to 3D dose calculation or dose cubes, using convolution even in our dose calculation algorithms, Monte Carlo simulations, balancing different clinical constraints in a complex environment all together in the past. So I know this next iteration is quite a quick one, but for us, I think we're probably one of the best skilled professions to deal with this type of change and these types of clinical automated tools that are AI-based tools. But I think we need to be cautious on our terminology. And this book, AI Snake Oil, had a brilliant opening chapter. And just the idea is that, like, if you imagine that we've used the collective noun vehicle for all types of transportation, bikes, cars, trains, planes, rockets, the conversations that we'd be having would be very confusing if that's the one collective noun that we have to describe all of those things. So could you imagine then for each discussion, one side is talking about this amazing performance vehicle that they've had, which turns out to be a Formula One car, while the other side is confused that their vehicle doesn't perform as well in practice. So they're talking about a Fiat Punto or something in comparison. So this is what's happening with AI. Commercial pressures means that these companies want to become AI-enabled companies. And they're very likely to slap an AI label on just, things that would have been previously just an automated tool or some sort of, statistical process or tool in the past. So it's something that we need to be careful of because we are talking about such a diverse range of tools with different skill sets and different abilities to deal with context and problem solving skills that, you know, if just using the word AI will not cut it, I don't think. For us, there's a really useful website, the little QR code up there. It brings you to it as DL in radiotherapy, deeplearningradiotherapy.eu. And it gives you a sense of all the commercial tools that are available at this current time. But what I love it for is to see how far and how quickly we're coming along. So this was a screenshot, or this was a capture that I took a few weeks ago, but I'm sure there's many more tools across auto segmentation, generative AI for imaging, personalized treatment planning, and imagery reconstruction and enhancement. And I'm sure these numbers have increased since. So it's a really good tool to see what's out there and what radiotherapy is implementing at this current time, but also that it's impacting every single aspects of our workflow. So it's coming quick. And I mean, this really shows you how quick it is. AI is kind of encroaching into every aspect of our working and daily lives. Telephone, 50 years for 50 million users to adopt. Netflix, 15 years. But then ChatGPT, 30 days. So it really begs the question of how quickly we can update our practices and procedures, education, competencies, clinical trials, our ability to, develop evidence to make clinic or proper decisions about how robust these tools are and how to safely deploy them and use them. And these things are traditionally very slow to change. So we really have to think about how we can adapt to the speed of change. And I think if we can, then we'd be in a really good place too. This is a key example that I've had from the past, which is really just, I think it really highlights it. But this paper looked at the AI generated medical advice and it was received for publication 2023. And if you look at when it was published, it was May 2025. So the model they used was ChatGPT 3. And if you look now at the available models for OpenAI, that model is no longer available. It's completely old news. So for us, the way we generate these papers and evidence does need to take into account that by the time something's published, it may not be relevant. And we really need to be cautious of that. So if we look to the future and see what is here or what's very close to being implemented very, very soon, I do think that what it will look like, at least from my imagination, is that a radiation therapist will be on a treatment unit for a patient's day one treatment or even somewhat throughout their treatment. And all of these steps will be implemented in one loop. So you'll have the image acquired, some sort of target IR segmentation engine will generate the contours, a plan will generate the plan, and the radiation therapist will be presented, or the unit will be presented with a new plan and having to make a decision whether to press the green button to go or the red button to stop and maybe continue with the old plan. This is happening now with the likes of hypercyclic variant, but I do think it'll be happening more and more very soon into the future, where all these decisions, responsibility, the data overload risks are going to all come to the LINAC, where the skill sets need to be able to consider and have a critical eye for what the output of these models will produce. It's something that we looked at in 2023. This was a fantastic experience. I'd advise anyone to do an Astro workshop. It's just such a great learning experience. But our task was a group of physicists grouped into different groups to come up with, each group would come up with a clinically deliverable treatment plan in an as automated way as possible. And it was a really interesting task, and I think we learned a lot from it. So for us, we found out that one, it was absolutely possible. I mean, Carlos Cardenas from the US created a single click where a CT scan was contoured, segmented, planned, evaluated, and sent basically for a possible treatment. That was a simple-ish clinical scenario for prostate, where, things that were, relatively predictable could be accounted for. But the questions then really and discussion really came to why isn't this coming about now for all treatments? Like what's stopping us from going to that next step to make sure that all treatments can be automated in single click type workflows? And it came about in the real world, it's not as simple as a prostate. There's a huge amount of variability from patient to patient. There's different risks involved, machine errors, patient consent, ethics, responsibility, and human oversight. So if anybody wanted some insights from the risk assessment that came as an output from that workshop, there's a really good paper published by some of the attendees here. But what we followed on with was what we can learn from other disciplines. This is a paper that we published to have a look at the aviation industry. So what can we learn from what aviation has learned over the past, because they've went through a huge transformation. They've went from manually flying airplanes with manual gears, flaps, and monitoring the weather, navigating all manual, to now an autopilot system, which kind of does a lot of that, if not all of it for them. They've been elevated to manage autopilot systems. And something similar is happening in radiotherapy. So we've come from manual style treatments, manual dose calculations, all the way through to now workflows that are very automated, where now we're no longer pushing in physical wedges. They're enhanced dynamic wedges, and treatments are generated very, very quickly in a couple of clicks. But what we can learn from this is that when autopilot fails, the pilots are still trained to take over. And that's what's really, really important. And when pilots usually take over is complex situations where the autopilot is not trained or able to deal with. So pilots need to maintain their skills such that when autopilot fails, they're not going to be dealing with a routine case. They're going to be dealing with a complex case. I think that's going to be the same case for radiotherapy, that when our automated processes fail, it won't be failing on a routine case. It'll be failing on some unusual anatomy, some unusual setup or treatment approach that needs the user to still have some skill sets remaining to deal with that situation. So what do we need to know as users or deployers of AI in radiation oncology, or just healthcare in general? And it's something that the breakout group was involved with, which was led by Anna here, as a model card. So it came up with a series of just, recommended and, other kind of fields that would describe a model for an end user to give them the information required to be in a position to effectively use that model in clinical practice. It included model input data, the model architecture, or kind of an idea of what approach was used in training, and also just what metrics were used and how you'd interpret or critique the output data. So, looking at the black box in the middle first, imagine a situation where you have a black box model where you know the input data and you have metrics that demonstrate the model performs incredibly well. So you have here some cells coming in for malignant and benign. The model predicts whether it is malignant or benign, and you have great sensitivity and specificity. You know, your accuracy was 87% for familiar cases, 85% for novel cases. Brilliant. I mean, it has the capacity to see medical imaging with a level of accuracy and generalization comparable to humans. Is that enough? How much of a black box do you need to understand if those are the metrics? Do you need to know the architecture inside? Do you need to know the number of neurons in the neural network or the loss function used? How about, is it just enough to know that where the limitations and strengths might lie? And this is a real published paper. And if you looked at it, and I'm sure some of you have seen it before, it was a pigeon. A pigeon was trained to learn what was malignant and what was benign. So for us, I think the model metrics are just one side of the story. I think you do need to have a little look or a little understanding of what the model was, what approaches the model might have used, or at least what approaches used by the people training the model, such that you have an idea of where the limitations might be. So I don't think you need to know the exact mechanics of the model, but I do think if you know, or at least get the idea that there's a pigeon or a black box is inside with some approach that you have some understanding of, I think you're much more likely to critically evaluate the output more closely. So looking a little bit closer and, some of the things that might help you determine a model's limitations and strengths. If you take the input to a model, I mean, I know we see three cute corgis here, but for a computer, all it sees is numbers. So, and the idea that the computer's trying to do is just some simple maths to basically figure out what features of this image correspond to predicting X, or what features in this image correspond to classifying a particular pixel as either inside or outside a structure for an auto contouring system, for example. For us, it's used convolution, and I know that sounds pretty scary. It is a complex term that people use, but if you break it down to its maths that works behind it, it's just a multiplication and a summation, something that all of us can do. So if you can imagine a filter here or a feature that is looked for, this is an X feature that is trying to find in an image. One's where the X is and zeros where everything isn't. If you place this feature all the way across your image and multiply each pixel with its overlaying pixel and sum the total, it'll get a high number where a lot of that X lines up with an X in the image. It'll get a very low number where there's not a lot of that X appearing in the image. So it tells you how much of this feature is present at any location in an image. It gives you an activation map or a convolve feature at the end. So it does give you an idea of what's in the image and where. So we've just developed now a very simple convolutional operation to figure out where X's are in an image. If you looked at something more kind of realistic now in terms of what you might look for, we can build a simple house or a building detector using a horizontal filter and a vertical filter. So here, multiplying this across the whole image and just summing the answer at each place, you get these activations that are highlighting all the horizontal bits and all the vertical bits. And combining these two together, then we have a house detector. So you can see how these models kind of build up features over time and figure out what features might be relevant for a particular solution. So we take it one little step further, and it's just, let's figure out how to build a model to determine if a mouse is present in an image or not. So here our feature is just a little curved line, for example. So 30 is everywhere that line is and 0 everywhere else. If you place it here on this mouse, you see that the curve bit lines up very closely with the bits of the mouse that's a curve. And when you multiply and summate the answer, you get a very large number. So the model is very sure that that curve is present at that point of the mouse. When you position it here, you can see a very low number. So there's no curve here in this mouse. So when we take it to the next step, you can kind of imagine then what different features you might need to determine if a mouse is in an image or not versus a car or a boat or a tree. And here you might have 6 features that individually you multiply it across the whole image and summate the answer at each position for each different image. And then you get the corresponding number. So if you have 6 features, you have 6 different activation maps. And using those activation maps, then if you can see that there's, a curve here, a nose here, an ear up here, and a tail here, types of features, you can then say, yes, we're confident that this feature, this image more than likely has a mouse in it or not. So bringing it back to the clinic, now I think we have a bit more skills to kind of figure out how an AI segmentation solution or something predicting if there's a lung nodule in the lung or not is present using convolution. You can see it might use the boundaries of the lung and the heart. You can see it might use the boundary then between the spine and the tissue surrounding the spine and what features it might see in every image that has a lung, for example, if it's trying to auto-contour a lung or not, or a heart or not. And what things might throw it off. So obviously unusual anatomy or imaging artifacts. So you might be a bit more sensitive then to those scenarios where these models might fail, just knowing how convolution might work and what features a model might have learned in an image. The other concept I just wanted to touch on was the evaluation metric. So once you put it through a network to learn what's in the image and where, you get a result. It has to be compared against ground truth. This is where the strength or the heart of a model really comes from as well. It's not just convolution, but how it compares against ground truth. It might use dice, it might use some version of a dice coefficient or Hausdorff distance or something else as an evaluation metric. Depending on the quality of your evaluation metric will depend on the quality of your model because it needs to correspond to what is clinically meaningful. And when you look at this talk, for example, by Thomas Janssen in the Netherlands, a brilliant speaker, by the way, if you get a chance to go to one of his talks, I'd highly recommend it. He made a very compelling argument that a lot of these metrics that we use for geometric comparisons don't correlate very well to clinically relevant metrics. So there might be a lot of space here for development of what is a really clinically relevant metric for us to use in clinical practice for training these models. My opinion then, moving away from the architecture, is where we really need, as end users and deployers of AI models, is actually a lot more information about the input data. So how the model was trained and how that input data relates to our local data, and also the skills for interpreting, critiquing, and using the output data of a model. I think that's really where the value will come for somebody who's an effective oversight person for an AI model. Looking at the input data, the idea, I think, here is that from this paper kind of really explained very well, is that we need not only transparency of how a model makes a decision, but transparency on the data to show where and how the data came from, how it was sampled, and what biases it may carry, so that we can compare it to our local data. So there's a lot of work, I think, needed in this area. And hopefully this makes the case. I mean, you can see here from the radiology world, looking at mammograms interpreted by 124 radiologists, you see a huge spread in sensitivity and specificity. In the radiation oncology world, where 25 radiation oncologists contouring different structures, what do you see again? You see a huge spread in what ground truth is, or where the structure boundaries truly lie. This is the variability both inter and intrapersonally that we're dealing with in terms of the input to models and what the model has to learn as ground truth. So I think expectations here, the height that we see in AI models needs to be tuned down a little bit to kind of reconsider it and compare it against humans, basically, I think is where we need to be comparing these models' outputs, is that how well does it compare against an average human? And if it's within that band of performance, I think we're in a good place. You think maybe more data is better, or garbage in, garbage out, you must have heard before, where 200,000 noisy labels reached the same or similar performance than 20,000 high quality labels. So there's a good argument, I think, for having high quality data instead of more data. And a number of different vendors really focus on that to try and say we are consensus driven, or we have really focused on the quality of our data instead of just getting as much data into our models as possible. But the algorithms as well, or the metrics that these models report, are basically summary metrics. So you might see a classification here or a detection, pathology detection model say that we're 95% accurate. Well, that might be 95% on average over all indications, where the performance on each individual disease type might change. So if you see here, the model was trained on a lot of different frequencies of different diseases, for example, where mass was or hernias had very little samples, whereas infiltration, effusion, and other kind of disease types had a lot more. And you can see the model performance varied considerably. So you really have to think about that in terms of your models, in terms of how does it work on each disease type or use case that we would have in our clinic, because it might work very, very well for some and it might perform very, very poorly for others. The other big data issue that we have that, I mean, I think it's a little bit untalked about or unspoken about is, I mean, a lot of public data sets are used for training. But when you really look into it, there are cohorts of different patient types that are very underrepresented. And here's one idea here, which is children. Out of 181 publicly available medical imaging data sets, children represented less than 1% of the data. And even more concerningly, all the pediatric AI models relied heavily on one dominant public data set. So for us, and this paper really makes this case very clearly, we need to really focus on the data and what data is used for these models. Because if you use one dominant public data set for pediatric cases and then assume your model will generalize well, it likely won't. And just the last slide to hammer the data home, really. If you look at it here, the percentage of female data in training even makes quite a considerable difference. Once it dropped below 50%, the model performance also significantly dropped. Even that was flipped for males too, so the proportion of males below 50% model performance dropped as well. So this idea that, I mean, it doesn't even have to be cohort driven or gender driven or anything in between. It's just a general concept that if it moves away from its training home, so here even this paper shows that from internal training metrics were quite good, and the minute it was moved to an external testing ground, performance dropped. So you can think about pulling a model from Germany or Finland or the US and using it here. It's likely not going to perform exactly or as well as where it did in its original training home. And you think you have it all sorted. Once you have the data done and dealt with, and you have a full understanding of your data and the local data, the data changes. And this is the concept of how do we keep up coming back in again. So here is a really interesting paper about data drift and how they tracked their data over time and figured out when data was drifting away from the model before or what the model was trained on. And they found actually that even the COVID-19 data drift shock had a really significant impact on model performance. And they retrained the model afterwards and it brought performance back in again. So when you think about what would change in radiation oncology, it might be HPV vaccination rates, cutting cervical cancer rates completely. So a model trained pre or post that might perform very differently. New lung screening programs or changes in health policy. So we do need models that change or can be updated over time. And a lot of the assumptions that the models are continuously learning, but they are not. Mostly they're static models that need to be updated in a binary kind of way to the next model version. And then looking at the last bit, so the interpretation, critique, and use of the output data. I think this is really important because as an end user, you need to know, can I trust this model's decision and how did it make its decision? For here, just imagine a busy clinic and a doctor has an AI model that quickly, looked at patient's notes and took details of a current visit and made a prediction whether a patient has the flu or not. So to fully trust the model's decision, they need to know what the model based its decision on. And in this case, using this line it's an older kind of way of doing it, but the model showed that both sneeze and headache contributed to prediction of the flu and no fatigue was evidence against with their relative strengths. So now the doctor can make a decision based on this information to either trust or ignore the model. And this explainability allows that end user to have some confidence in the model's prediction and really bring it into context with the patient to make sure that it's actually facilitating their clinical practice and the safety for their patients. For imaging, there's a technique called GradCam, if you ever heard of it. It's basically a dose or a heat map where the model was looking when it made its decision. Now, GradCams don't tell you why it made a decision or how it made its decision. It just shows you the portion of the image used to make the decision, whether there's a giraffe in the image or that there's a stop sign in the image here in this case. And this is a really great paper for kind of emphasizing this exact benefit for it. So it's basically classifying wolves and huskies, whether an image had a wolf or a husky in it. And it performed very, very well. So it had a really good accuracy. But when the model trainers flipped the narrative around and said, well, where was the model looking when it made its decision so that we can figure out if this model will generalize well to world data? It turned out they made a snow detector. So the model was actually looking at the background, not at the huskies or wolves themselves. I think some of the cohort was just pictured on a snowy day versus the other cohort was not. But it gives you an idea that, immediately this model won't generalize well to a bigger, world-side population. In a clinical example, this is a really good case. So it's a case of just chest radiographs across 3 different institutions. And it performed again very, very well. It had high accuracy across the metrics or the diseases it was trying to predict or kind of figure out what was in a radiograph or not. But when they looked at where the model was looking to make its decision, it was really focused on this top left corner of the patient's left shoulder for that laterality token. And when they investigated a little bit further, they found out that the laterality token mattered because that institution, that only 1 out of 3 used it, had a higher prevalence of disease. So what that meant was if we then use this model and we use the laterality token with a different prevalence of disease in our center, it wouldn't perform as well. It's looking for something non-clinical. It figured out that there was a hack or a cheat to get good performance on the data set it was trained on. So in radiology, this it kind of comes back to what I started with, was where you place AI in the chain changes the both clinical and operational type of outcomes. So for example, there's different scenarios where, for example, scenario one, an independent human um, and an AI kind of independently read on a particular radiograph, and then if they disagree, another human might, interpret it then and make a final decision. AI could be put in individually with no humans. Both humans could be supported with AI, or AI could screen things initially, and if there's high risk or low risk, then it could go to humans to make a final decision again. So there's lots of human factors to consider about how you marry up AI with humans in different workflows, because radiologists, for example, might become over reliant on heat maps that are not perfect, maybe being reassured that if no heat map exists, and that means there's no small lesion that it might have missed. And radiologists often follow the AI's lead, so effectively turning off their own critical search patterns to determine if something is there or not. And the whole idea of satisfaction of search as well. Once you see a heat map and one abnormality, you're a lot less likely to spot another. So have a look at this image for me and see that lesion down the bottom left side. I mean, this would be quite a nice example of how this works. So a radiologist might see that and see a heat map and go, yes, that makes sense. There's a little lesion there, a nodule, and we're really happy. We'll send the patient on for treatment there for further evaluation. But this was a really interesting study, and it's a famous study again, that showed that even expert radiologists can miss obvious abnormalities. And I don't know if anyone has seen it yet. Hopefully you haven't, but um, here was the title of this paper, which might take you by surprise. So the invisible gorilla strikes again. And if you can see up here in the top right, you can see a little gorilla hiding in the image where 83% of radiologists didn't see the gorilla. So you can see then that you might be led by these kind of heat maps, and it might be very misleading if relied upon. So a lot of human factors need to come back into the AI's mix into clinical practice. And it's not just the physics behind it, it's not just the workflow implementations. There's a lot of psychological input, I think, that's needed to make sure that, we do these things effectively. In segmentation, I mean, there's lots of ways that these uncertainties can be portrayed to us as well. So here, for example, you can see kind of an uncertainty region of each one as the contour, where the model was either uncertain where the boundary lied because of the model input data varied a lot. Humans didn't agree a lot in this region, or it didn't based on this person's anatomy, it wasn't sure. So you can see that, I mean, this can be very valuable for us in terms of showing us where we really need to focus on segmentation and clinical segmentations that come out of these models, but it may also be a distraction too. So there's a lot of different ways we proposed, and this paper made a really good case of, seeing which one would be most valuable in clinical practice and safe to implement. So if you want an idea of what they came up with, have a read and it'll show you which one of these solutions they found was the most beneficial in clinical practice. So that kind of follows kind of skills to kind of know what or how effective human oversight might be done in clinical practice and what skills you might need to know or be aware about. I did want to touch on some kind of solutions that are here now and just to see what we can learn from them as well and what's been published on a lot of these solutions to kind of help guide our clinical practice. So for auto contouring, we published this paper recently where we implemented it clinically for all patients in 2023, and we saw some huge task time savings, up 70% for complex cohorts. And we did find that patients were ready for treatment on average 2 days earlier. So plans got to that end stage where they were ready to start treatment, and it was significant up to 5 days for us. But what we did actually also find was that there was no CT treatment workflow benefit found. And the idea here was that we give our patients start dates in advance. So it really made us rethink about our workflows where we'd have to really optimize our workflows to take advantage of this benefit, because if we didn't, we wouldn't see that CT to treatment benefit that we assumed would be just a byproduct of implementing auto contouring in the task level back here in the workflow. The other thing we found was we did look at a year post monitoring um, worth of our data as an audit. We found that yes, although before implementing AI prior 3 years, things were increasing because task complexity was going up, case complexity was going up. But after implementing auto contouring, yes, we did see a step change for the task level, but then that segment of the workflow actually just saw this change in trend more than a step change that continued to decrease over time. So two things came to mind. One, maybe we're just using AI more optimally. We're embracing it better. We're implementing it better into our workflows. Or two, it could be a combination of that plus some sort of complacency or over-reliance. And it turned out when we looked at it, that was there. So we were being led by the auto contours that the AI model was producing. So it was in the magnitude and direction of raw AI, which is that orange contour in the middle or orange box spot in the middle. So that was a little bit concerning for us. We needed to dig a little bit deeper. When we did, we found it kind of fell into three categories. So one, it was actually for some cases, AI was just a little bit more right, which was a bit of a surprise. So we found that in some cases, AI just got it closer to consensus than we did. And it was more down to the kind of previously we used thresholding tools or other ways to contour, and now it was just that little bit more automated. It allowed us to be that little bit more correct. Then when AI gets it mostly right, and there's a lot of contours that fell into this category, where it was just systematic changes that we could learn and introduce into our, education training and checklists. For example, the spinal brain interface was always just a couple of slices off. Then lastly, where AI gets it very wrong, and this was that outlier where the model wouldn't have seen an anatomy like this and it didn't know where to place the contour, and it got it very, very wrong. So this shows the importance of, 19 out of 20 cases that might be good. That 20th case might be so wrong that it would have a very significant clinical impact if we weren't vigilant. This is the idea that I went back to that aviation example with when autopilot fails, pilots still need the skills to take over when autopilot is wrong. And it's often in not a routine case, it often fails in a complex case. So here, our radiation therapists and radiation oncologists still needed to maintain their contouring skills to deal with this situation when it arose. For generative imaging, it's a whole different kind of ball game. So if you've seen this example before, it's really where, it generates a new image from an input image that comes in. If you've seen the Samsung phone scandal, it was like you take your phone out of your pocket, take a beautiful image of the moon, and it'll give you a DSLR quality image. And the idea was that it wasn't actually giving you a raw perfect image of the moon. It was almost superimposing what a moon would look like based on its training data in this circumstance. And the scandal was apparently if you pointed it at a white circle on a black background, it would fill in the moon too. So it fills in, the idea of generative models is it does fill in the gaps based on the training data. So if you think about that, you really have to think about, is the information in the raw input image in the first place for it to have made that decision? Because what you don't want is for it to add in or take out things that aren't actually there in reality. So you really need to take a kind of a kid approach to this, where, we've no ground truth. So we did need to embrace our inner child and just try to break the model and see where it went wrong to learn its limitations. So not only what happens when we do X, like image it with a field of view that's smaller or a different image quality, but based on us being human, what happens if a human just decides to use it in a weird or strange way? So I think we learned a lot from this process. Here, we just threw everything at it. We threw image quality at it, field of view at it, air pockets where they shouldn't have been, orientation and field of view scenarios, and it performed incredibly well. For us, it built up a lot of confidence for us because it got HU differences correct, it got dose differences correct, and for converting cone beam CTs into clinically plannable images, I think even from my perspective, I was so impressed. I was like, this is really, really good. But taking that how do we break it approach did actually result in a number of scenarios where um, you know, interesting things emerged. So for one, it removed contrast. So it did kind of make the images a little bit closer to what we treat, but it was just useful to know where it just blanketly kind of put in a uniform density in that region where the heart or traditionally was higher in when we use contrast. But also this scenario here, which is a lot more clinically impactful, was that when we put in an MR scan, which had a craniectomy, it filled the bone back in. So if you imagine this is an SRS intracranial case, filling in bone where it shouldn't or isn't in reality could make a serious clinical consequence that you need to be aware of. So this is something that both the human and the machine may not spot because in MRIs it's kind of harder to see bony anatomy, but when you see the CT scan itself that corresponds to it, it's very clear. So it's something to be aware of. The other thing I did want to touch on was foundational models. I mean, they're emerging more frequently now, like ChatGPT, Gemini, etc. But the idea of a foundational model is a model that can adapt to different tasks than those they were originally trained upon. So they're trained upon a wide corpus of data, and they can be then basically fine-tuned or pointed towards different tasks they wouldn't have seen. But it means that they're harder to interpret the results or cases where the model might actually fall short. For us, the idea of putting in loads of different medical data from different sources means that it might learn a lot of features or complex interactions that we wouldn't have known about before. But it would be almost like a model to fit them all. So it'd be a task that could, or a model that could then be pointed to different tasks in the radiotherapy workflow and be very strong and robust at dealing with those tasks. However, there's a lot we need to know. So this is our first kind of delve into it. And Sani, our network practice tutor in St. Luke's and the clinical specialist too, was very interested to see what we can learn from it. So he kind of fine-tuned one of the models, so ChatGPT, towards our corpus of public data. And he's assessing it on both patients and staff members as well about like could it answer clinical questions in a safe and effective way. So there's a lot of information we're going to be getting from that pretty soon, I hope. But there's huge potential here. Could you imagine a busy clinic and years worth of data is summarized into a single summary where the radiation oncologist or doctor would have never been able to do that in the first place while there's 40 patients waiting outside? There's huge potential. But it does mean that our prompts matter, and there's a lot of education I think we need to do to brush up on having a strong and powerful prompt to make sure that we get the answers we want. Two people sending, a prompt into a large language model will get two very different answers. And I do think there's a lot of learning we need to do to get an effective prompt to get a very robust answer. Just a very crash course, quick one slide to give you an idea. I mean, here, if you look at tokens that go into a large language model, they're all given an index or a number. It might be 4, 5, and 6, but they're not very useful mathematically. So they're just indices for the model to look at because if you see the difference between these, I mean, there's a 1 in the difference between black and apple and also white and apple. It makes no sense. But these are just used to look up vectors in a different space. So one vector might be just say a 3-prong vector, whether it's a color or not, whether it's dark or whether it's a fruit, 1 or 0 in each one of those. These are multi-dimensional vectors. But the minute you get this idea that it's just a vector in some sort of space, then you can compare one to the other to see if they're close together. That means that they're very related concepts or words. If they're far apart, they're very far apart related concepts or words. So this paper did a great job at explaining this. So the idea of radius being a bone or radius being a mathematical concept is two very different things. So if you include words around that, that's how the model knows what domain you're speaking in and what to predict as the next word, So then it can go and say, well, we're talking about radius of the distal radius or proximal. They must be talking about anatomy. The next word must be, something related to that. So if you wanted a crash course in it, this paper is a brilliant way to start. And I think the consequences it can be quite severe if we don't take a critical eye to the outputs. They're so eloquent and so grammatically correct, but they also have fabrications, hallucinations, negations, everything we need to be aware of. And this paper really did summarize that too. And the concern as well is that it can be more persuasive than humans. This paper showed us that using an LLM can convince people more powerfully than a person can towards an incorrect or correct answer. Legally speaking, could you imagine if you were a jury or juror on a jury and a radiologist missed a diagnosis, but the AI said that there was a lesion there? The jury would side, according to this paper, with the AI model and say the radiologist was incorrect or at fault. But the minute you bring in all this information I've kind of been talking about in this lecture and the context, so maybe the AI model was wrong 7 or 8 times out of 10, the context of this patient mattered in the decision. That's when the jury then would swing more towards it being a reasonable answer for a radiologist to make in this situation. So I do think these skills are things we need to build up and support our teams and doctors kind of in these difficult scenarios. So I just wanted to give you one slide. If you wanted to upskill in large language models, I think there's 3 papers I think you should take and or at least start with. One is this tokenizer playground. You can have a look at how things are broken up and how things are tokens are made for clinical text. Grounding, how you can actually use text to give you better answers, to ground the model in something, a knowledge base, to give you a much, much stronger answer, and also context, the idea of how to make a really strong prompt. So if you take anything back from LLMs from this, I hope this will help. And just to finish kind of up a little bit more on what we can do now. So, I mean, the learning I think is really important. So when a student uses an LLM, what prompt did they use? Is the student questioning the response? Can the student comment on the answer? And I think the educator and student are in the same boat. And we need to promote critical thinking. So discussion, evidence, feedback, teaching, and engagement using this deft AI kind of framework that they quote in this paper. So I think AI used with a critical eye alongside experienced staff, both the experienced staff member and the learner will be in a good place to learn about this fast changing world where we're all learning about AI, no matter what level we're at. As a little sneak peek, I think I can kind of back that up with some data. And I mean, here we did a knowledge assessment of 500 participants, and two kind of key take homes that I can share with you here, which is quite interesting, was that there was no difference between career stages in model performance or kind of AI knowledge, showing that educators, trainers, and everyone in between, and learners from that are just starting, we're all in the same boat. And also that AI is changing so quickly that a certificate or degree might not give you as much of an advantage as maybe taking seminars and workshops in these topics. Because if you can think about a seminar workshops over a day or two or a week, whereas a certificate's over a year or more potentially. So, there might be a benefit then to consider how quickly things are changing, and workshops and seminars might actually be very advantageous in terms of upskilling in this area. So to finish, I think my solution, or the solution that I think I'd recommend, is really what this paper kind of outlined, is an algorithmic consultant. Could you imagine we rely on radiologists for imaging, pharmacists for safe drug use? Maybe we do need to have clinical staff that are upskilled to know model limitations, performance on local data, defining domains of use, and advising on best use and keeping up to date with change. I think there is a space for this now because it's such a fast changing environment. So I hope that if I could summarize the whole talk, that the hard truths that we've kind of dealt with or learned will help us see through the hype and hopefully make AI safe and effective for our patients and workflows. So I do think all these lessons will translate across medical fields. And I do think that, we do need to invest in some education in AI, because if taking George's box's last word, the words there, I think would be a good thing to end on, is that if we consider all models that are wrong, but some are useful, I think we're in a really good place. So thank you very much. I really hope it was interesting.
Great, Karen. Thank you very much. That's certainly a lot of food for
Mm,
thought. Yeah, and I guess from listening to what you have said, I guess we have a lot to learn when we're using AI, and it can teach us things. And there, that about the radiologist and the missing the elephant in the room kind of thing when we're so focused on looking at
mm,
one thing. And I just wonder say for student medical physicists, RTTs, and radiology colleagues coming in the future, they won't know what they don't know.
mm,
And they're working with these technologies, and for example, maybe in contouring, they may not know the nuances of contouring certain structures because they haven't actually done that manually.
mm,
And how, I guess, can we, coming from my own point of view as educators, to start with maybe, and then thinking of managers and people in the
mm.
clinic, how can we um, equip them to know these things or to be aware of where the challenges are or where the difficult cases are with AI?
It's a really good question. It's a really difficult question because I think
Yeah.
we haven't really come across this type of huge transition. I mean, I know the internet came about before and we thought it would ruin education. We saw the calculator come up and we thought it would ruin people's math skills. So I did see two kind of very big kind of groups emerging, or kind of sides of the argument. One is, do we need to know anymore? Which is an interesting take. I'm not too
Hmm.
sure I'm fully convinced with that. And also, the other side is that, yes, it will impact things completely, and we do need to know. I mean, if you take the aviation example, they do simulations and training um, in circumstances where when autopilots fail, they still have the skill sets to manually fly that plane. And I think where we should be in the medical setting, because as I mentioned, when AI fails, you do need those skills to take over. But I do think that paper that I kind of referenced one or two slides back, which was probably the closest take of where I would sit with it, is that both educators and trainers are in a similar boat with this. Is how do we have a critical eye for AI's outputs? What can we learn from it? And I think the experience from the educator and the trainer kind of going through those circumstances where you question the output. How did you think that model made a decision? What prompt did you use to get to that point? What did you think of the output? And can you back it up with evidence in your own words? I think those type of kind of scenarios or those kind of tutorials or practical kind of situations would be really beneficial. But I do think we need to embrace it. I do think we need to use it in as many different circumstances as possible, because only through using it will we really know the limitations. So I'm not too sure if that answers your question, but I do think shared experiences with educators, I think are is the way to go.
Yeah, no, I mean, I don't think there's any answer, but yeah, I think
Yeah.
that's, yeah, certainly food for thought. I might take a question from the group. So, Karen is wondering, so are there any free models that we could use as RTTs for creating stats for day-to-day practice and research that we could use to work on?
It depends on the area, and
Okay.
there's plenty of open source models out there. I mean, there's like a full segmentation type of model that you can download as well. I can't remember what it's exactly called, but I can share it if you wanted to send on your email. I can find it for you. But there's also all the large language models too. I mean, they're not just ChatGPT, Gemini. You can download an open source, open weight model and use it locally as well. So there's loads of things you can do. But if your question is more about data sets, maybe, and things you can play with,
I think so.
I think that's, I mean, there's huge amounts of public data sets you can download and use models on in an open way. I mean, it's something that I think there's one group who are very prominent on LinkedIn. I'll have to look them up again, but they are actually creating almost like a database of all these open source models of different situations, like 4D CT scans or clinical text that have been uploaded as parts of different research or different projects or international collaborations that are then free to use in certain circumstances. So, I mean, there's certainly a lot of options we can use. And lean on instead of using our clinical data. I mean, that's probably a great place to start, because using our clinical data, as you all probably know, is incredibly difficult in terms of consent, ethics, and GDPR.
And I guess arising from that then, because we were looking for data that's applicable to Ireland and applicable to our
Mm,
population,
yep.
and
Hmm.
then we have data protection,
Mm,
and then we're forced to use these open source data, which may not replicate our patient population.
exactly. Yeah.
So
Yeah.
it's kind of like a chicken and egg kind of thing
Yeah.
where,
Hmm.
but I guess in hospitals themselves, they may have the opportunities
Mm.
to use their own data.
Yeah, I mean that's I think the idea of transfer learning is really important, because you might be able to train a model using a huge corpus of data that's publicly available, but then bring it into your local site to fine tune it on your data, or to at least kind of, because then if you can only get a couple of patients to consent to use their data for training a model, for example, that might be a nice way to do it, is to, use a huge corpus of data to get your model right and learn very generalizable features, then fine tune it on your local data before moving it clinically. But then everything from MDR comes in too. How are you going to use it? It's a complex um situation to be in, I think, outside of a clinical trial setting or something.
Michelle, you have a question.
Mm.
Yeah, thanks, Ciaran. I always have so many questions after listening to you. Yeah. It just you just realize how little we know when I hear you talk. It's quite remarkable. Yeah, I think that's quite interesting. I was thinking of the Mastro paper, the Philippe Lamban one, the radiomics one, of course, which I'm biased towards, about the model that they set up in lung cancer, and then they
Mm.
were able to validate it in head and neck, which like no one could ever believe could be done, but they actually were able to do it. So there are some generalizable features probably, but in reality, is a model developed in Ireland on, Caucasian males on low risk prostate cancer going to be predictive in,
Mm.
upstate New York. I mean, who knows? It's hard to know, isn't it? But anyway, I had a two-part question for you. One was just when you were showing all the things about that you felt you were drifting towards the AI rather than your own kind of I suppose clinical knowledge. Like how do we stop that kind of confirmation bias? You know what I mean? You kind of think,
Mm.
oh, there it is. It's like you see some people get their news on Facebook and think, oh yeah, I'm right because it's on Facebook. I
Mm.
mean, how do we stop that from happening? I think with AI is the first one, and then the second one is in your group. Of fellows, what did you think about the ethical acceptability of using AI to patients? Like our
Mm.
patients, what do you think patients would think, or do they know that we use auto segmentation and we use things to do this? And should they know? I suppose that they're my
Yeah.
two questions here.
It's a good question. I mean, something we've learned with this year was, yes, we found bias there. We've looked at it and we've implemented checklists and some education sessions. Now, about a year in, we've re-asked the question to see, like, are you aware that this structure is a systematic bias present, or is it a random thing, or is it perfect? Is it a commission or omission error type of idea? Um, and we were a little bit surprised that, it was the ones with checklists and a bit of education and training were more recognized, but I think a continuous monitoring is needed. There's some tools that are coming out now commercially to allow us to do this, and I think that feedback loop it needs to be continuous. It just has to be continuous to kind of get to keep us from creep towards an AI output. And towards your second question, if you just remind me again, it
Sorry,
was
but the
about
ethical
the ethical,
acceptability
yeah,
of
for
using
patients.
AI.
Sorry, yeah.
Yeah,
I
yeah.
mean, we're actually talking a lot about this, and it's something that I'm not 100% sure about because if I was a patient, I would certainly like an AI model to be a guardrail if you think about it that way. But I'd still want the human to be aware of me as a patient and what my concerns might be or where I might draw a line towards risk or toxicities. Um, but I do think it would be, um, if a patient then was given an option to say, well, it's going to be a busy clinic. The consultant will have 10 minutes with you in a clinic to get you assessed for a follow-up or another reason. And you have 20 years worth of clinical notes. The consultants won't be able to look at it. Would you be happy with AI being given your data and it'll give you the consultant a summary of your 20 years for you? And I mean that some of those patients won't even remember a lot of things. They might have cognitive issues at that point or other kind of secondary issues that might make it very hard for them to fully articulate their vast medical history. I think, at least from my perspective, I would probably lean on that. That would be beneficial more so than risky.
Mm.
So it's a difficult one, and I think it's something that I know Jill, the other research fellow, is really keen to
Yeah, Jill's
engage with
really
with
interested
with,
in it.
with
Yeah,
breasts. Yeah,
yeah.
she's really gonna
Mm-hmm.
do full sessions with it. So I think
Mm-hmm.
if I was asked this question, maybe this time next year, I'd have a very robust answer for you,
Yeah,
what patients actually
yeah.
think.
I'm not even talking about them as
Mm,
summarising in the clinic. I'm thinking more about
yeah,
when we take informed consent from patients.
yeah, yeah,
You
yeah.
know, do we
Mm,
actually tell them we're using
mm,
AI as part of your treatment?
yeah, but it
It's
depends if
quite an
it's an
interesting dilemma, I
yeah.
think, isn't it? I mean, I don't think there's any answer to it. I'm just
Mm.
interested in what you thought about it, you know?
I do think if it's a workflow tool. I mean, we use dose calculation, optimizers for planning. We use lots of things that are almost could be slapped with an AI tool on top. And I mean, we don't tell our patients that we use those workflow related tools. But I think the second it crosses into a decision making
Mm,
aid or
yeah,
tool, or that's really where that line I would say
big,
needs to be
a big
drawn.
difference.
But I do find it very funny that I mean I've been asked this question exactly what would patients think many a time, and I often find it funny that people are asking a physicist what a patient would think.
Yeah, yeah.
It's
Well, I know you've been working with some excellent therapists
I
and
know
an excellent
definitely
radiation oncologist, so
that's what I
it
was
might
clear
have
about from
rubbed
the
off on
start
you.
is that the benefit for me is working with Jill, Sam, and Claire, the research
Yeah, of
fellows as
course.
the
Yeah,
MGT, which really brought a proper perspective
yeah.
across many angles.
Brilliant. Thank you.
Yeah, no worries. Thanks for having me, though. I really appreciate it.
Great. We might go with one other question. We have about
Yeah,
two
no
minutes
problem.
left.
Yeah.
So quick rapid fire buzz around here. A question from Angela. So brilliant talk. What do you see the future of the Linac team changing in your Back to the
Mm.
Future Linac scenario of fully automated planning and treatment?
Yeah. I mean, what we're kind of focusing on a lot now is kind of like automating the workflow for simple cases like breast or for even bringing a head and neck case from 15 days to 5 in a fast turnaround. And now the technology is there to let us do that or at least start to think about it. But I do see a lot of these tools, if you can imagine the full radiotherapy workflows, that series of tasks that need to happen. And where do you put humans in that workflow? And I know that automated workshop that we did, we were kind of thinking, should a human not just be put at the end? Because it's so fast at that point. If something's wrong along the way, surely you get a human to see the full output, get to assess it in totality and see the impact of any differences or changes along the way and make a decision to use it or not. So for me, it's kind of like that rare ethos type of scenario where it's probably going to be a radiation therapist on the treatment unit being presented with something and needing to know, can we trust this output? Is it better for a patient or worse? What's the impact of that change? And it's a lot of information to process in a very stressful situation. I mean, I've been on Linux and seen the kind of complexity that can happen with, patients having bladder filling issues and challenges, having to be brought on in a very timely manner, while complex decisions on a patient setup need to be considered too. It's not an easy situation. And I do think AI will help us there, but I do think it's moving a lot of the problems right down to the LINAC to have to consider as well. So
Yeah.
that's kind of
Yeah, I
where I
guess.
see it going. Yeah.
Yeah, and I think like you always talk, it just comes back to patient safety. I mean, that's,
Mm,
and
yeah.
is that plan safe to
Mm.
deliver for that patient? Okay, unfortunately our time is up, everybody. Thank you for the questions and for joining us today. Ciaran, thank you very much. That
Well,
was
thank you so much for having me. I
really
really appreciate
insightful.
it. Yeah, no problem. Thank you so
And to
much.
remind everyone that the webinar is recorded and will be on our Discipline of Radiation Therapy at Trinity College Dublin if you want to look back at that excellent. And there's loads of resources there I think we can look back on in the next few days. Great. Ciaran, thank you very
Thank
much.
you so
Thank you,
much. Cheers.
everybody.
See you soon. Thank you. Bye bye.
Bye.